How y'all doing? Good. Sounds like y'all had a long day. So I talk fast and I tend to walk around a lot. So if you have questions while I'm talking about something, feel free to just stop me and ask, because if not, I kind of just move along. My presentation will only last about 20 to 30 minutes. As she was saying, I met Kim Smith several months ago. I was looking to start an outreach program for our hospital for helmets for kids. And then as her and I got to know each other a little bit more and more, she was asking me if I knew anyone who could do a presentation on PostCrash Care. So I was kind of laughing because I told her, well, I started in EMS in 1995. Then I started to think about my time frame of how old I'm getting. But became a paramedic in 1997, worked on the streets up in Milwaukee, Wisconsin for quite a few years. That's where I'm from. And then ultimately moved down to Florida in 1999. While I was working as a paramedic, I started flying for First Flight, which is our local helicopter system here. And I got my registered nursing degree. And then I started working as an RN for several years while I was still flying. And then I was still bored with that, so I had a late life crisis to go back to medical school. Found working with my hands was kind of fun, more so than working in the emergency department. So still had a love for trauma though, so then I thought it would be more fun to go on and do a trauma critical care fellowship after that. And here I am now at 50 years of age. Instead of giving the patients to somebody, I'm actually receiving them. So it's kind of come full circle. My wife did not appreciate that, but it's been a journey. So I do have a few years of experience in post-crash care and what it exactly means. So we'll go through slide by slide here. I will admit I'm not the greatest presenter in a big group of people, but I figured I had enough experience I could probably muster through this for you guys. So again, if you have questions, just let me know, okay? So we'll elaborate a little bit more on this scene. Most of the pictures that you're going to see in this presentation are actually mine. There are a few that we've taken from web sources and stuff. However, I happen to be sitting in the front seat of the helicopter getting ready to land. This was on I-95. This was quite a few years ago. It was a pretty devastating accident, multiple fatalities. But this is just an outline of what we're going to talk about. Nothing really to elaborate there. This is even funnier. It's funny how things come full circle as we're preparing stuff. And a couple mornings, my normal ritual is wake up at 4 a.m., get my coffee going, turn on the news, and start listening to the news. And a little clip they had on the news was talking about the infrastructure bill and how they're trying to allocate more money for us to have safer roads. And then they were starting to talk about statistically how we've had almost a double number of fatalities from 2020 to 2021 on our roadways. So then I was thinking about my little statistics slide here and popped it open when I got to work and realized when I look at the amount of trauma alerts that we've had at our system, Holmes Regional Medical Center, we've gone from 2020 from 557 up to 720. It's about a 30% increase. And the main thing I noticed at that point is we are doubling, and it's only getting worse despite having safer roads, supposedly more technology in our vehicles and stuff, so we need to do something about it. So my job is to talk about immediately what happens exactly after a crash. Anybody here ever heard of the golden hour? I know law enforcement probably has, because they're usually the first people on scene, but sometimes what we call the first critical 60 minutes. Just want to spend a minute and kind of tell you how that came about. So back in 1976, there was an orthopedic surgeon who was also a private pilot. He was flying in Nebraska, and he had his wife and his 3 kids on board, and he unfortunately was involved in a crash. His wife was killed instantly, and his 3 kids were critically injured. And they landed in a cornfield, and by the time he got help and got to the primary institution of care there, he had very substandard care at the institution. And he realized at that moment that if he could provide better care for his family out of the cornfield instead of a small institution, that something had to be done to change the system. So a bunch of local surgeons at that time, including this orthopedic surgeon, established a group that came up with something called Advanced Trauma Life Support. And they established the first course in 1978. It was then that they realized that this first 60 minutes of care for these patients in these crashes was the most important. Their research at that time also noticed something called a trimodal distribution of death. that we usually see death happen from injuries and accidents in 3 different time periods. The first one is usually on scene, and that usually happens within seconds to minutes of the accident actually occurring. And that usually involves traumatic spinal cord injuries, people who stop breathing because of traumatic brain injuries, or a lot of times the major vessels in your heart or your body tear apart and they bleed out. And there's not much you can do about that, except for preventative care, which is why we're all together today to figure out how to make roadways safer. The second peak usually happens minutes to hours after the accident. And this usually happens because of traumatic brain injuries, people collapsing lungs, people dying of acute blood loss from either lacerated spleens, livers, or organs. And those people we do have a chance to make an impact on if we can get to them in that first 60 minutes. And then the third phase, or the third peak that they noticed, was weeks to days later, days to weeks later. And these were patients that were dying of something called sepsis or multi-system organ failure. And again, it depends on what kind of care we provide up front to prevent them from getting to those later stages. So having an understanding of that first 60 minutes throughout the rest of this presentation really realizes that time matters, and that time starts the minute of that accident. So the first thing that happens, and I'm glad there's some local law enforcement here because they're really our first line of defense for most of these accidents, is what happens when you first get on that scene. Usually that scene has got chaos, it's unsafe. Often there's people running around really wanting to be helpful but not sure what to do. And the best thing they can do is use the 911 system. 911 system will call a local dispatch, which is usually our local police, and then they will contact the Brevard County Fire Rescue. They will get information from whoever's calling, and then they will dispatch the appropriate personnel, whether it's ambulance, do they need heavy equipment, do they need hazmat, do they need multiple fire engines. So the more information that can be provided by that, sometimes it's helpful. As far as like locations and stuff go, I think everybody here probably realizes with my audience, we have things called mile markers. You know, I think I've landed over the last 10 to 15 years in probably every mile marker on I-95 at some point for an accident. But a lot of civilian people don't realize that these little mile markers and stuff can actually help give detailed information as to where the accident is. And that can help save time for EMS and law enforcement to get to where they actually need to be. I'm sure they'll tell you best. There's nothing more frustrating than trying to hurry up and get to an accident just to find out you're in the wrong location. And that often happens. So how did they get there? Again, this was an accident on I-95. And you can see the backed up traffic. That's actually heading southbound. The vehicle that is in the middle of I-95, the SUV, was actually traveling northbound and collided with that van that was heading southbound in a head-on collision. And unfortunately, there were several fatalities on that scene. But the main thing to take away from this is if you look at the emergency lanes and you look up the backup traffic, it is very difficult sometimes for the engines, fire rescue, law enforcement to get through this traffic and actually get to the scene. This is another accident off I-95, and the thing I wanted to point out on this one is if you look at the bridge on the bottom right corner, you often see people who get impatient, don't want to be stuck in traffic, and they start using the emergency shoulder. And then what happens is that starts to get backed up. And I'm sure everyone at some point in their life has realized you hear the lights and sirens behind you, and you realize they have like nowhere to go, and it becomes chaos. These are the things that I felt like over the years of being in the back of an ambulance, being in the front of an ambulance, is areas we have to find a safer and faster way for our law enforcement and our EMS personnel to get to these accidents quicker. Landing zones for us, this is an area I have quite a bit of experience at. This is Cape Canaveral. That is probably one of the nicest landing zones we actually have in the northern Brevard County. Not only is it a beautiful view to just come in and land in, however, it is very safe for us. It's well lit, it's free of any overhead obstructions and hazards, and it's completely blocked off. And plus we usually get security from Cape Canaveral Hospital that also blocks it off for us. But all we need for that landing zone is about 100 feet by 100 feet. And as they know, we land everywhere. We land in backyards, we land on I-95, we land in parking lots, we land in fields, we land just about anywhere you can put us. The main thing we have for criteria really is that it's free of overhead obstructions, free of any kind of debris, free of trees, and most importantly, free of public people trying to run up into our area as we're trying to come in and land. This is just another picture to kind of point out, if you look very closely just above the helicopter there, it's a very good LZ. It's wide enough. It's at an intersection where it tends to be a little bit wider. Sometimes we get quite a bit of debris at these intersections. However, you'll notice the power lines just above and beyond. And those are the things that we fear the most, especially at night. We cannot see them, so it is truly up to our law enforcement and fire EMS to help establish these safe safety zones for us. I really think, as I think about locations in Brevard County, we have a few special parking lots and stuff that we use, kind of from some of our deserted shopping malls. I think even just up here off of US 1 on the right-hand side, we use that one on a regular basis. We use Cape Canaveral's LZ for Cocoa. Down south, again, sometimes we use Palm Bay Hospital. But sometimes it's pretty difficult to try to land on scene. I apologize, I didn't put law enforcement on here. However, from a fire EMS standpoint, as far as who shows up, I will say law enforcement is usually our primary people who show up on scene first. They truly establish a safe environment for us. They block traffic. I'm sure they can probably tell you horror stories of people who are impatient and don't want to wait and will continue to try to drive around the accident scene and stuff, and they make it very unsafe. I've come in for landing zones on I-95 and had traffic going around literally trying to drive right under us as we're coming into land. It's really unbelievable. But people who show up, firefighters, EMS, EMTs, paramedics, and then if you have fire rescue, usually flight RNs and paramedics, and then also our law enforcement. Their training goes anywhere from EMTs, which is about a 16-week course. They provide something called basic life support. And then they move on and become paramedics, which can be anywhere from a 4-year degree, where they learn a little bit more pathophysiology, anatomy, and advanced care, what we call advanced life support, to provide a little bit higher level of care. They start IVs, they're able to intubate or provide airways for patients. And then if you're getting into the flight crew, they go through specialized training as well, and they usually have a little bit more advanced training as far as some of the medications. They administer blood, and they're very good at their airway experience. This is just some pictures of Brevard County Fire Rescue. It was a rollover burn on the top left, and then just some of our training that we recently did. Going to briefly, so you keep hearing me talk about a trauma alert, and anyone familiar with what a trauma alert is? I keep saying this term. A few people yes, some people no. Trauma alert is a notification that's initiated by EMS. They usually are notifying our hospital system, telling us that somebody meets some of the criteria on this card. And because of this criteria, then they issue a trauma alert and they're letting our hospital system know that somebody pretty sick is coming in from a crash. If you go under the Florida Administrative Code 64J, they have a whole library full of definitions and what constitutes creating a trauma alert. This is for the state of Florida. It's pretty well known. I'm not going to go through every one of these in detail, but just know in the previous slide we talk about training requirements and stuff. Most of our fire EMS have this memorized. And the funny thing is, if you look, there's on the top, you're going to first notice there's an adult trauma alert criteria, and on the right there is pediatric trauma alert criteria. Both of them can have one thing to constitute a trauma alert, or on the bottom part of the card, any two of the following. So if you look on the bottom, for one of them, age greater than 55. Most of you know in Brevard County, our general population is probably over 55. So they almost qualify right there alone just by age. At the very bottom of both of them, you're going to see judgment by EMT, paramedic, or other healthcare personnel. Even if they don't meet one of these criteria on this card, The paramedic, by their judgment, based on the mechanism of injury, based on how much damage there was to the vehicle, how fast the vehicle was going, they may say, listen, yeah, they don't meet this criteria, however, I have a funny feeling something's wrong with this patient, so they'll use paramedic discretion, and they'll still call or issue a trauma alert. We don't mind. We'd rather have them over-issue a trauma alert than under-issue it. And back on my statistics slide, one thing I didn't explain is we also do something called inter-facility trauma transfers, meaning that if a patient doesn't meet trauma alert criteria here, they may be taken to a local hospital such as Parrish, such as Rockledge Regional, or Melbourne, or Palm Bay, and then they do their workup in the ER, and all of a sudden they find out they have a head bleed, they have multiple fractures. It's something more than their system is capable of taking care of. We will then accept those patients as what we call an inter-facility transfer. And that happens just under 1,000 times a year for us on top of all our trauma alerts. If it's a pediatric patient, and when I say pediatrics, I mean anything under the age of 16 years old, they will need to go to a designated pediatric trauma center. Most available trauma centers we have for pediatrics in our area is Arnold Palmer Hospital in Orlando and St. Mary's down in West Palm Beach. If they're in crisis, if they are not breathing, they have no pulse, it is more than the EMS personnel can handle, they may divert to our facility initially, we will stabilize that patient, and then we'll ship them to the appropriate facility. Same for burn patients. Burn patients require a burn specialty hospital. That is a complex patient to take care of post-operatively. Our two closest burn centers are Orlando Regional Medical Center in Orlando and then Jackson Memorial in Miami. And they are primarily dedicated to taking care of burn patients. Any questions so far? So I'm kind of motoring along, trying to captivate your attention.
Doing great.
All right, thank you. So, that pre-hospital transfer of care, what happens? That paramedic gets on scene. They determine that this patient meets trauma alert criteria, now that we know what it does. They will call dispatch. Brevard County Fire Rescue will call the dispatch center for first flight, and they will issue a trauma alert. Tones will go off at first flight hangar. They will have a pilot that will initially check weather. They will determine that they have appropriate height of a ceiling for visibility and a certain amount of forward visibility before they'll even decide to take off. If they don't meet that criteria, and it may be sunny out at the accident scene, but between that accident scene and where they leave from, there may be bad weather. They will turn it down for weather, and then the ground team is responsible for getting that patient to the trauma center. Most of the time, if we have weather like we did today, and we were just laughing saying, I left work early today because I wanted to come give this presentation, and not even 1 minute after I called my partner and said, I'm leaving for this presentation, the trauma alert pagers went off. And I don't know if you guys heard first flight fly overhead, but there was an accident here in Rockledge just a few minutes ago, required prolonged extrication, so good day to fly. I was in a helicopter. It was about the shortest clip I could find for you guys. The one, show a good landing zone. 2, you can see the wires. 3, you can see debris in the air. However, we do have law enforcement helping us establish a safe landing zone as well as fire EMS. We're lucky enough here in Brevard County. First flight, that's a Eurocopter 135 helicopter. It's got the capability of doing about 150 miles an hour, and they're able to carry. We used to carry 2 patients if they really need to. We usually just carry 1. But again, they have 2 healthcare professionals that are in the back of the helicopter. One is a registered nurse and paramedic, and the other one is a paramedic. But all of our nurses who are also on that are also dually trained and also pre-hospital care. Again, they are trained in advanced airways. They actually carry blood. They carry fresh frozen plasma. They carry platelets. They carry medications for advanced care if our patients are sick. Their job is anywhere north, all the way as far as Titusville, all the way up into Mims. We will give support to the eastern Osceola border, and we go all the way down into Indian River County. They also do something called interfacility transports, where they actually will take patients from one institution to another. So if somebody was in an accident up in Titusville and they needed to get to our institution and they needed to get there kind of in a hurry, we'll utilize the helicopter to go from hospital to hospital. Just a brief word about mass casualty. It's been a long time since I've actually been on the streets for an actual mass casualty, but I can distinctively remember a bus crash that I had many years ago on 528 right into St. John's River. The bus actually went into the river, and it was full of people. And mass casualty is just when casualties exceed the resources that we have. In a little bit, I'll talk about levels of trauma centers. However, if you have multiple patients at an accident scene, sometimes you have to be able to have the ability to start to designate where they go. Again, that comes with the training with our local law enforcement and also with our fire personnel, that they'll determine who's walking wounded, who needs to go to an actual trauma center, who could possibly just go to a local hospital and initiate care. We do some annual training with mass casualty incidents. I think it's something we probably need to do more of, because it's one of those things like the pulse, accidents aside, you just never know this day and age when you're going to have a massive amount of casualties at once. And I think, again, that's a system thing that we need to work on to provide better care. Levels of trauma centers. In the state of Florida, we usually designate only level 1 or level 2. However, in some states, they'll go as high as level 5. Really, the main difference here to show, for example, Orlando Regional Medical Center is a level 1 center. They are capable of providing care for all aspects of injuries: pediatric trauma, burn trauma, hand surgeries, amputations, anything and everything they're capable of. They also are a teaching institution. They have residents. That's where we learn as physicians. They have surgical residents, and they're able to provide all of that care. Level 2, except for a teaching institution and some specialties, we're usually able to provide that care from the beginning they hit our trauma bay all the way till discharge. Unless you have very strange injuries and you need advanced specialists, that's about the only difference between a 1 and a 2. This is Holmes Regional Medical Center Trauma Bay. I actually took this picture just a couple weeks ago when I heard I was going to start taking this presentation. It was just a typical morning. I was driving by, and this is what our trauma bay looks like on a pretty normal basis right now. Our volume and census is probably at the max. Right on the very top there, you can see our helipad. There's actually a helicopter up there. It's just a rotor that's sticking out. They have an express elevator that goes right down the shaft and drops it right into our trauma bay. So once the trauma alert's been issued, they come to our trauma center. They're going to arrive to the top left corner. We have designated rooms that are specifically set up for trauma victims. They consist of specialized equipment such as monitors, mechanical ventilators, special lights. We have the capabilities of opening up somebody's chest or belly right there in the trauma bay. We put in central lines. We keep emergent blood, platelets, fresh frozen plasma, all in the trauma bay ready to go. Usually by the time we're done doing our initial primary assessment and we're getting ready to send the patient either to the operating room or to imaging or to the surgical intensive care unit, on the bottom right, that's usually what the trauma bay looks like after the initial resuscitation. Some worse, some better. We do try to be clean. It takes an entire team for us. This is a minimal list of who's actually involved once a trauma alert is issued. It is a system-wide activation once we know a trauma alert is coming. There's always one trauma surgeon that'll be kind of the captain of the ship. After that, we have registered nurses who are trained in trauma, respiratory therapists. We have case management to deal with family members, clerical, radiology for interventional radiology. Laboratory gets activated, blood bank gets activated, surgical intensive unit gets activated, the operating room gets activated, so it's a full-line system. That way everybody knows that if we need to keep moving and try to achieve that 60 minutes of care, that's kind of where we go. So that's kind of our benchmark. Specialists that we have that are all within a phone call away and being quickly at our hospital include vascular, cardiothoracic, urology, oral maxillofacial surgeons. Our two most common that we use along with us ourselves is the orthopedic team and neurosurgery. Our highest population, aside from motor vehicle accidents, is falls for elderly. Somewhere usually between the ages of about 75 and 95, and they're usually on some kind of anticoagulation. So the initial workup, as I talked about in the beginning, Advanced Trauma Life Support is a course that's been put on by the American College of Surgeons Committee on Trauma, and they help all physicians, not even at just our institutions, but smaller institutions, start with a primary survey, a survey that starts off systematically, no matter where you are, no matter what institution you're in, to provide a higher level of care and as efficiently as possible. Without that, the problem they had back in 1976, they realized that it was very haphazard treatment. They didn't have the equipment and supplies necessary, and they didn't have the resources. This course has been going on for many decades now, and it's worldwide. We follow all trauma ATLS guidelines, and it helps with the skill set for us, and it also helps the patient in the long run. This is just the initial scout film of a patient. You don't need to be a radiologist to look at his right femur. It is completely fractured. If you look at his humerus on the upper right arm, also fractured. Once we go through and make sure that they don't need an airway, they don't need us to assist them breathing, we don't need to give them blood, and their blood pressure is normal, then we'll move on to something called ultrasound. We'll make sure there's no internal bleeding. If they're still good from there, we'll send them something called CAT scan. CAT scan is a very detailed picture, usually from head to toe, to look for any kind of internal injury. Once we've done all that, and we also run some labs, we'll make a determination whether or not the patient can go to the operating room, or if they need to go to the surgical intensive care unit or the progressive care unit. This is what our normal operating room will look like on the left-hand side. Once we're usually bringing a trauma in, we quickly and expeditiously get them into a special operating room that's set up specifically for trauma. We're often using something called Cell Saver, where we can give them back their own blood. Blood bank is usually with us as well, preparing if we need something called massive transfusion protocol. On the right is just myself and one of my partners operating on a patient. Once we're done with the operating room, they're going to go to the surgical intensive care unit. Here we have nurses that have been trained in critical care, and they are able to provide a higher level of care, and it's a specialized level of care for our trauma patients. They're able, a lot of times when we operate on somebody, we don't just do one operation and we're done. We have to sequentially take them back to the operating room. So we'll purposely leave bellies open, we'll purposely leave chests open, and these nurses know how to kind of take care of all of that. They're very versed in dealing with some of our advanced ways of technology these days, probably better than us. Any patient that requires ventilatory support needs to be in an intensive care unit. Once they finally have done well and they get out of the surgical intensive care unit, they'll move to the progressive care unit. It's kind of like a step-down unit for us, and then this is when they really start working with our therapists. Most trauma patients require care from occupational therapy standpoint, physical therapy standpoint, and often speech therapy. These are patients whose lives have been dramatically changed because of their car accident, and sometimes we have patients that'll stay with us for several months before they're even capable of making it to a rehab. Once they make it through that, then they'll eventually make it to a outside facility, such as C-Pines. If they've had a spinal cord injury or some kind of neurologic process, then they'll go to something like Brooks, where they specialize in spinal cord injuries. Sometimes we're lucky enough and patients can go home with just home health care. A good majority of our motor vehicle accidents, a lot of times, will sustain multiple orthopedic injuries. Not something that they necessarily need to go to inpatient rehab or something for, but something they still need some assistance. Any of you have ever broken a leg or an arm, you realize very quickly how debilitating it can be for a little while. Once we're able to get them to go home, we have an office in our hospital that's on the first floor called the Physician Specialty Office. This is where we follow up all of our trauma patients. A lot of times we're removing drains, we're taking out staples, we're removing sutures, and we're doing some follow-up imaging. Preventative care, which is the whole reason I think I'm really here. So again, Kim's already established helmets for kids, which I just think is phenomenal. I'm hoping to work with her in the near future here to get even more kids with helmets. But I have to have some athletes out here who at least enjoy biking, running, surfing. And the first thing I think about is I like all three of those. And I used to be an avid person out on the roads and cycling every day. Nowadays, I'm so afraid to ride my bike on the road because I'm so afraid of getting hit by a car. I'm a surfer. Crossing A1A is probably more dangerous than me going surfing. And unfortunately, this year alone, we've had several fatalities in Melbourne Beach already for people just being struck on A1A by vehicles. I didn't put it on here, but I really think texting and driving is also probably our #1 corporate right now for a lot of the problems.
Does anyone have any questions for Dr. Zenoni?
Go ahead, back to the hospital.
I want just best case scenario, everything falls in place, they get the traffic. So if you've got to run, like say, out to 95 right out here, Rockland, East, kind of midway through our county. How long is it, the call process and all of that, helicopter gets up, before that person starts to get that basic trauma care? Because they're getting basic care at the scene, obviously.
Yeah.
But best case scenario, how long is it?
Good question, and it depends on location. Some parts of our county are a lot easier to access than others. Just for example, getting beachside, it's so close, but it can take so much time for EMS to get sometimes. We have fire departments set up down there, but I always use I-95 as an example because that's usually a common place. We have most of our bad motor vehicle accidents. If anyone's driven down 192, all the lights, all the traffic, that is a solid 15, 20 minutes. I don't care if your lights and sirens and you're trying to get through traffic, you're going to take 15 to 20 minutes to get on scene. Once they get on scene, they have to determine how many patients, is it a trauma alert or not. That usually takes about 10 minutes for EMS. They can do this quite rapidly. If they issue a trauma alert, First Flight has a benchmark of being off the ground in 10 minutes, meaning that the minute their tones go off, they can have that helicopter out of the hangar, fired up, and en route within a 10-minute time span. Once they get on scene, they have another benchmark of 10 minutes, meaning that they will provide any immediate care they need to do on scene, same as EMS, but the lingo is load and go versus stay and play. Again, the golden hour, 60 minutes. Anytime you're wasting on scene is time you're wasting because ultimately what somebody needs is to stop bleeding, to get an airway for them. And EMS is learning to be able to provide some of that, but if you ultimately need surgical intervention, you have to be able to get to us as quick as possible. And that's one of the biggest struggles we have is time, especially with some of our roadways.
That sounded just from what you were going on, like there's 30 minutes,
Yep.
kind of at a minimum.
Yeah, so
that's
that
why
really
it's-
gives us any time. That's why we have to do such a rapid assessment and then determine whether or not what we're going to do.
So
I don't know how many people, I think anybody here has heard lights and sirens come from behind. I was always taught, you move to the right. Ask these guys, does anybody move to the right for you? Does anybody even try to get out of their way for you anymore? They just don't. It's like a different generation. It's unbelievable. It's frustrating.